Rhode Island, so just right south of Boston. And I remember like going trick or treating with like a parka on,
Yeah,
like winter.
yeah.
It could be.
Has Dr. Shanoff on here to start the meeting off, but I don't see him in attendance, so I don't know, Lauren, if you want to just go ahead.
So we are quarterly, that's due twice a year next year, health center and health plan update.
Yeah.
Here, Kenneth got called for an emergency on his way here, so he will be en route. And,
See, we're gonna hear. Jay.
Jay Miniotti is,
Jay was not able to make it.
Jay.
so we're
Mary.
yeah, it's that time of year.
So that's it. Any other questions?
And we're done.
I wouldn't mind taking some time back in our day, but
He did prepare an actuarial report he was going to go over.
I was looking forward to
The information is
that.
here, and he will provide a written commentary.
okay.
So Barry, you're up.
Page 5,
I'll say, what page are we jumping to now?
no, we're not gonna do
Want to
anything
go
on
to
Jay?
page 5?
Did you wanna,
Or is
let's
that-
go over Jay's stuff, I mean,
Yeah, I can go over it.
Okay.
You want to go over Jay's stuff? Okay, so we got a pinch hitter here.
Okay.
Okay. So, I'm not an actuary, but we work alongside Jay closely as we go through the reports. My name is Mystery Slonick. I'm the account executive on the advisory team. So on page 5, we're going to take a snapshot. It's a 3-year look back of the STOC claim profile. This is specifically looking at large claims over $100,000. And the reason this is important is because this is comes into play for your what we call shock claims. These are your large claims that we want to keep a close eye on as they approach the stop-loss threshold and towards the stop-loss reimbursement. Now, of course, you guys have a very large stop-loss threshold, and then you have the aggregating threshold. But as we approach these large claims, then we can implement case management and get different metrics going to help contain them and to ultimately find the best care for the member as well as saving the plan money. So when you're looking at that 3-year threshold or 3-year look back, the ones in orange, all of them are an average. So the overall 3-year average is 58 large claimants over 100,000. October 2022 through September 2023, you had 62 on average. For the 2021 to 2022 plan year was 62, and 2020, 50. So when you're looking at the previous 3-year average, significantly down, and that is, I think, in a large part because of the great programs that we have in place for case management. And again, the next page on 6 is looking at your per employee per member or per month rolling 12-month claims. This is incurred claims, and these are excluding your health center and RX rebates. So this is pure claims, pure medical and pure RX claims. And you can see the rising trend line on, and we broke them up, the orange dashed lines in there are break up your plan years. So we've got the 2021 plan year snapshot and your 2022 plan year snapshot. So while it is inclining slightly, it is pretty stable overall if you're just looking for a claim standpoint. And then Jay also did a snapshot of incurred claims and a trend so that you can see first-year trend, second-year trend, three-year trend average. And you can see first-year trend from 2019 to 2020 to 2020-21. Of course, we did have COVID come into play at that time. So you did see a negative 13% first-year trend and some other factors going on as we moved into different TPA, different plan modifications, different case management, wellness features as well coming into play. But overall, for the three-year trend, we're looking at the 0. All right. Going on and looking at a dollar rolling 12 incurred claim for medical and RX. This is again excluding the health center and RX rebates. So we do have a rising rolling 12-month incurred claims. But again, the important thing is to note here in the green bar on the end is that in 2023, this current plan year that we just started in October, is that we've made some significant plan changes there with the new health center plan, and that should bend the curve of the rising claims that we're seeing.
On a graph like this, and they put there like what the percentage is? Because if you say, oh, it's increasing, I get it, but it's increasing 3%, 10%, you know, what's the?
Sure.
Just for
Yeah. Yeah.
display purposes.
Yeah, make a note.
Good question.
And on 9, this is a claim projection that Jay needed based on gross numbers before any plan changes. So just looking at those medical and RX claims in that golden bar, roughly 62 million. Taking into account plan changes with the migration savings, we had roughly 1,000 employees move to the health center plan. So taking into those factors, roughly a 3% savings there. That was a $1.86 million adjustment. So afterwards, that gross is with the after plan changes in the migration savings was roughly 60.1 million. Factoring on RX rebates of 1.3 million in savings. You're looking at a net estimate of medical and RX claims of 58.88 million after plan changes, migration, and rebates expected. So roughly looking at around 5 million a month in expected claim activity, purely of those medical and RX claims, not including the health center and other fixed costs.
Oh, sorry.
So I know I went through that pretty quickly. Any questions?
Yeah, on the rebates, what is the delay in the actual cash receipt? Because you may be eligible for rebate. Is it taking 3 months, 6 months? Do we have 100% rebate redemption? You know what I mean? Or is it like maybe 90% of the rebates we projected actually became true? Like sometimes they may debate it or something like that, you know, as far as.
We saw a study of that earlier about the discounting promise versus the discounting achieved, and we were ahead, but I don't think that report was run this time.
On the-
Integra sends us rebates as soon as they get them to the system, so we get a monthly check back through the rebates. It's not like Cigna. Cigna used to hold on to 6 months or more for the rebates.
And they are lagged by about a quarter.
Yeah,
We're going- you know,
we get a
you
quarterly
get-
report.
The rebates you get today is for activity from a prior period.
Right.
But
So
they-
I guess the point is, are we collecting all the rebates that said that we're going to receive?
That is definitely very much audited by the pharmacy vendor that we have and of our independent pharmacy advisory team that we have.
Yes.
They all monitor that very, very closely. But we have to monitor sometimes there's a cost of something domestic, and then we have a rebate associated to it, and then we have to net that out compared to other ways of buying it. Is international less expensive overall? Sometimes it's not. So we have to measure the whole net process, and then also waiting for our money back versus, having a savings now.
Recently, we took some of the pharmacy that was sourced internationally and brought it back to domestic because in looking, the trends had gone that direction.
Now, who collects the money, like physically? Like when we get the rebate, is a check made out to the school district of Osceola County and does Sarah Graber make the deposit? Or does Proventure get,
We
whose
don't
name
touch-
is
we
it
don't
in?
touch any
Whose
money.
name is the rebate in?
It goes
I'm
back
not
to the-
implying
it goes
anything,
back to the claims
I just want to know
fund.
transactionally, because it may not always be.
We have a shared account with Integra Integra, and they automatically deposit it for us.
into the claims fund.
You said it was trending in that direction. What did you mean by that?
Cheaper in the US for some versus international.
I
Is
think
that the case?
Barry was talking about, I would think that what he was
What was
referring to is
wrong?
insulin.
Oh,
Insulin,
yeah, I'm sorry, yeah.
So drug prices are getting cheaper in the
No.
United States than elsewhere. So what is the trend exactly?
They fluctuate depending upon sourcing and the PBM, pharmaceutical benefit management world is really a black box. But as we look at the cost of things over time, if we notice there's an anomaly, we take action. It's one of the good things about having a self-built, actively managed plan.
Such as?
Carolyn?
What would an
please?
anomaly be?
oh, so
looking
I was,
Insulin?
I was talking about the insulin. Insulin over the past year or 2 years has been decreasing in price. And also, we had a lot of members on various insulins, so we were able to streamline that process and get us on the most cost-effective insulin in each of the categories. And then when we compared it to international, there was not a huge disparity. So we said it makes sense to bring it back to domestic. So we then had to work with the members that were.
What's the size of that disparity?
As far as the cost goes, I mean, that's all, the analysis is all done by the Integra at that point, so, you know, it's
Well,
a
let's
net
get
net.
that.
We could get that
Yeah.
answer.
Like, yeah, what would be the threshold that would cause it to be more effective to be here as opposed to following this effort that you guys have been making?
Yeah. Well, I just, and that specific was the insulin at that point, so we can share the whole report on the insulin, yeah.
You know, diabetes medications is our number one pharmaceutical script. Second are the anti-inflammatories, Humira, things for psoriatic arthritis and things like that. And recently, biosimilars have come out. And a biosimilar basically says it is chemically identical. And we're discussing ways that would significantly encourage people to use biosimilars rather than the brand names. And the battle we fight are these coupon programs where the manufacturers are saying, hey, we'll pay your copay for you. So on the brand, because then the large cost is passed on to the health plan. And we have to devise ways to counteract that.
We've got so many-
Biosimilar would be like a generic, right?
In layman's terms,
Right,
yes.
which is what I am.
Yeah.
Right? So
Right.
so this generic drug is cheaper than what the drug would cost internationally.
Significantly, yes.
Okay.
Yeah, and some of those are not available international, some of them are. But when you have it, it's available now at this generic form, like 20% of the cost. But the member has nothing out of their pocket either way. So it's trying to have the members understand, although you're still getting it at no cost, it still helps the school district
I think it-
if you switch over, and that's the challenge right
Isn't
now.
that part of the education of the doctor, though? Because as a patient, how do I know what's the best
Correct.
medicine for me?
So it's
You know what I mean, I
educating
know it's a
doctors, too.
business
Yeah.
world now, but I mean, like, you know, shouldn't we educate the doctors, let them know, hey, be aware that, you know, the generic, you know, is similar in effect and potential or whatever.
The pharmacy reps are there just telling them it's not.
The opposite.
So,
That's
yeah.
actually one of the projects.
And they
that
have tickets to the
Prescriptions-
ballgame.
yes. The Prescriptions Unlimited is working with us on. They're contacting the doctors or the ones that are going through his pharmacy, since he does the specialty fulfillment for us, to try and educate the doctors and the patients to move them over. He's gotten one so far. That's one win, but it's very hard to switch somebody that's already on a regimen. over.
Yeah, if you're already there.
Yeah.
And there is an aspect of lobbying to it.
Yeah, just a little bit.
To the point that Mr. Arguello was making with regards to the analysis, like how often do we run the analysis of cost, or so that, because it seems like, just based on this conversation, there was a couple of times we switched strategy, so how often are we looking at the cost analysis and then deciding what is best for?
So we always hear from the industry when certain patents are going to be expiring on drugs. So if there's a famous drug, or like for the famous drug Humira is where this biosimilar was coming out. So we knew that in advance of 6-9 months beforehand. So we had discussions about where's the price point going to be once it's released and things like that. So taking action and being prepared for that, and then watching it for the first couple of months to see what doctors are doing for the members, and then taking the appropriate recommendations from there.
So there's
it's
no
very much a team approach as far as how the market is doing, what's going on with new drugs being released or coming off patent, and how to switch them out.
It's ongoing, really.
Yeah.
But quarterly at least. And we actually have, if you look at 27, we'll get to it a little later as well, but we have the Milliman Sky Sale report, that's the annual report, that has some really cool information in there about the different drugs and some, we did, earlier this year, midsummer, we did a cost analysis on GLP-1s, Ozempic, some of the other diabetic type 2 medications, and that we're seeing a really high trend for off-label use.
Well, yeah, but I think that's a good example. First of all, we talk to Ventegra, our PBM partner, monthly. And I didn't want to give you the impression that the velocity of these changes are very rapid. But we have to watch the trends and be ahead of it to the degree that we can. With the Ozempics of the world, this year, the whole industry, the whole
Country.
population got really into using diabetic drugs for weight loss. So you have Trulicity, Wegovy, Ozempic.
Rybelsus.
Right. And the physician community said, this is not what this is for, which is why it's called off-label use. Well, we saw it in spades with this group. I mean, we had like the use of these
Hundreds of
drugs
thousands of dollars
went
increase.
way up. So we actually took the step of saying that you cannot use these drugs for anything other than what they're prescribed for. And we're facing a little bit of friction from that because your membership doesn't understand the actual dynamics behind it. But it's the right thing to do, not to mention for the intense side effects that people have been experiencing.
They're starting to discover those. Thank you for that. One additional question with regards to watching the trends. If a patient is using X drug and they've been using it for a while, we discover that a different drug or a different drug, not a different drug, what's it called? The
Biosimilar, that
An alternative drug?
Biosimilar, yes. Biosimilar drug will be better cost-wise. Do we change that patient, or this is just, we have this
That's
information
the
moving
doctor.
forward? Okay,
That's the
Right
relationship.
now, we're letting it happen organically.
okay.
Because it's again unfair to the patient to switch them from
Sure.
something
Yeah,
that's
that was
working
what I was getting to.
on
Okay.
it. But we do have formulary changes, like we move things from one tier to the other, so the copay might change mid-year. Ventegra likes to do those July 1st and January 1st. We give employees letters 6 months in advance because they're required to do that. This says your medication is now switching to a different tier. It might be opposite, might be going generic or whatnot, so they can switch over to the medication, so they get ample opportunity to switch with their doctor.
And we're able to mitigate that across the board, whether they're in the health center plan versus they're seeing an external doctor.
It's the
that's
same.
part of our-
Same exact
Doesn't matter what.
Okay.
Yeah.
And when you said we've gotten one doctor to come on board, it's just one doctor.
One prescription so far.
So it's because Eric is being proactive and taking the approach of calling the medical professional, and as a professional, having a conversation about, let's discuss this member and what they're currently on versus this is another opportunity, and how chemically the equivalence of that, and have that discussion and saying, can we move the member over as a cost-effective way?
And Ventegra has negotiated behind the scenes with the biosimilar companies to give us 3 months free health plan. We can switch them over, so it's a good deal if we can switch them over. It's just, again, we're letting it happen organically because we don't just want to switch somebody to a different medication.
The challenge, as we've mentioned before, with the coupons, because the member's already not paying anything right now, because the manufacturer's giving them a coupon. So the new company's giving that to a free, but to the member, it's already free. But there's a $5,000 fee behind the scenes that's
How long
going
does their
on.
coupon last?
They get renewed
Indefinitely.
every year. It's a 1 year.
Oh, wow,
Yeah.
look at that. I thought it was like a
As long
coupon,
as
like
they're
a
on it.
one-time redemption. No, they're just like in a forever.
Yeah.
The
It
larger
usually has an
challenge is,
annual limit of dollar amount, but it is evergreen.
I think the bigger challenge is having members feel like they have an interest in the outcome, right? And so, and the only way that you're going to do that is by them sharing the financial benefit of good financial decision-making.
Yeah.
So if they're not, then why would they care? I mean, you're not going to make somebody switch their medication, something beyond personal, right, for the sake of you saving money on some, or from Rosencare saving money, or, you know, or these profit margin. Profit margin versus medication is not a hard decision to make for somebody as an individual.
Well, and that's why every chance we have, or we can take, we make, like, if you get your Humira from overseas, it was free to you, as opposed to $200 copay if you bought it domestically. And again, with these coupons where the manufacturer is saying, we'll cover the $200 for you, it's a battle.
I think you could get 90% compliance where they would allow you to make the decision on their behalf if you said to them, listen, if we save $3 million in pharmaceuticals next year, that $3 million is going to directly benefit the amount that you pay for your insurance.
Profit sharing,
Right.
as it were.
The
We've
challenge
used that
is
elsewhere.
having member
to make them work.
outreach with PHI and having, the challenge of having anything outreach right now is people aren't answering their phones anymore.
So true.
You know, so letters at home, emails, member outreach is very difficult.
Your point is well taken.
Yeah.
I hope we're in a position where we can consider some sharing. So,
There's one last slide for Jay. He'll go into more depth on his write-up for this, but just kind of to summarize, he's looking at these by carrier or by vendor for paid claims for 2022 to 2023 as he's making his projections for the budgeting for next year. Factoring in how many claims are coming in by vendor, how quickly they're being covered, and what the claims overall are by vendor. As you can see, we had some run-in from Aether. Those are, as of 10/1, those are being stopped. We do have a few trickling in, but the majority of those are going to be going away. Same thing for Medical Cigna. We're still seeing some checks coming in for reductions there, so we'll be seeing those dropping off as well. You can see the RX rebates coming in. Again, those fluctuate over time, but all of those are factored into his projections.
on page 12, I would preface this by saying, in my long experience, and I think the experience of the rest of our team, there's it's not a saying, but there's a prediction in the self-funded world that every 5 or 6 years you're going to have a bad year. It's just, the nature of the flow of health. And this past year, we saw an increase in medical and pharmacy claims. Interestingly, more than 70% of the increase in cost is a result of an increase in underlying unit costs. And I think this is because underlying contracts are adjusted somewhat regularly. Medicare, while they hold the line on what they pay, does have escalators in it that cause the cost to go up. And a lot of our payments are based on the multiple of Medicare. And I think a study would suggest that prices are adjusting coming out of the pandemic period, where a lot of providers and suppliers are playing a little bit of catch up. But we had our costs went up, the funding went up. Unfortunately, the funding went up by about 4%, and the cost went up 6%. So we're watching this.
Funding's going up this year. The funding didn't go up that year.
Well, it went from 58 million to 60 million.
Oh, I think I meant the P, yeah, I'm
No,
sorry.
in addition to that, as Carolyn pointed out, we did adjust the board share of contribution, which we think will help offset that. We also, and this was in play way before we had a chance to review these financial results, but we started back in last December or January developing a new category of plan that was based on enhanced primary care through the health center. So we had 1,000, 1,300
1,000 employees, 2,000 members.
1,000 employees opt for a plan that allows the health center to be their primary care and to control referrals and medical care, which is intuitively the way healthcare ought to work. We're looking at the nature of the migration, and we do find that some of your riskier folks are taking that option, which is a good thing because they're entering into a more
Meaning
controlled
the-
environment.
The more health care needy.
They're going into the
Yeah.
healthcare plan, the health clinic plan, is that what you're saying?
Yes, and that's wonderful
Yeah.
because they get more resources there. And so obviously if they get more resources, then they get more time with their caregiver, then they get compliance will happen and things like that. So more under control than in their independent system out there.
A couple of things about risk. In this time period, which ran October 22 through September of 23, the essential plan cohort had the best risk scores of the entire group. The advantage risk stayed steady at about 1.23. And interestingly, those with employee spouse coverage have the highest risk score when compared with family or employee and child. And I suspect that has to do with the fact that those were empty nesters, and as a result, a little bit higher age. So you would expect risk scores to go up.
Now, on line 3 in the health center though, because you look at medical claims, 45 to 44, everything's been relatively stable. The health center went from 3 million in 2018 to 19, so it's almost 6 million, almost double. You know, and if you figure, hey, 10% increase in the health center costs every year should lead you to about 40% increase.
We were expecting that, and Kenneth would need to speak to it, but we were expecting that bucket to fill up.
Yeah,
Yeah,
we've
it-
hired a lot more staff is in there than before.
Yeah. And more
services that are being.
Because that provides
allocated.
tools to help us to lower the total net cost.
In 2018, Advent Health
That was
ran
Advent.
your health center
Oh, so that was prior to you guys taking over, so
Yes.
so what year did Rosen? take over?
19.
in 19.
The
And
second column.
that's when we, the Rosen Health Center took over and added services and brought overall costs, as you can see in that year, down precipitously. But we continue to expand the effectiveness of the health center. And again, I wish Kenneth had been here. In fact, I was kind of excited, Lauren's, mentioning maybe even having a mobile component to the health center at some time in the future. Oops.
Well, and as we push people
It's just an
hopefully
idea.
to engage in the health center plan, obviously cost there is going to go up, but with the hope that overall cost in other areas will decline.
But it was planned. So there are certain silos within our whole kind of ecosystem that we know are going to fill up, but we want to pay more in those silos because those provide the tools to help us
'Cause that-
reduce the overall
'Cause I
cost.
think what would help too is in these updates, if we had like a regular budget to look at, and say this year, this is the planned budget, because we look at, for instance, we look at individual schools, like if we sit on a charter board, we'll see and say, okay, this much goes to instruction, this much goes to utilities expense, this much goes to whatever. It would be nice to know what is the cost component of that, and what are you guys doing? When we do these updates, are we 60% of the budget, 80% of the budget more? Because I've never seen us sit there and say, okay, we reached a threshold of a particular line item, what does the board think? I don't think I've ever had this conversation.
No, you haven't,
Well,
but Sarah
but Sarah, yeah,
just
Sarah
recently
addressed that.
said, we need data that tracks exactly what you said against what, not only the budget, but what is coming out of the trust fund.
Correct. So I think that, so I guess in the future, if you guys can update that, if you can just have a traditional healthcare center budget, attached to this. And again, it should be your basic line items rolled up into one, like, okay, these are salaries and expense for the doctors, these are the staff members, this is the utility expense, this is the number of medical expenditures, Band-Aids,
That would
whatever.
come from the health
So,
center.
yeah, so we do have, Kenneth submits that to me every year in the detailed health center budget. And that total is what's rolled into the budget that you all approve. If you,
Yeah, we would like to see
if
that
you
as
wanna
a
see the
supplemental
detail of
schedule
that, I'd be happy to sit
kind
down
of
and
does.
go over that with you.
Yeah. So I'm pretty sure somebody has
It's
to have
just-
one.
It's at a level of detail that doesn't really need to be public as part of the budget process, but I'm happy to go over it with you all individually.
No, I still think, I think it is a public detail, because It's our cost, you know what I mean? Like how we, now it doesn't have to be like the individual salary of an individual person, but you can sit there and say salaries, expenses, $2 million a year, Rosen admin fee, 1.4 million a year, you know what I mean? So I think how much
I'll
we
get
spend on
with Kenneth
supplies
on
and
something
things like that.
appropriate.
So it could be rolled up. It doesn't have to be so granular, we have to see every single line item, but, to see some degree of a budget, I think is appropriate.
Well, and we can roll that up to a total budget to compare against the overall health plan. So-
Yeah, because direct effect to, anything we do at the health center directly affects the claims going on in the outside bucket. So we always call it little bucket, big bucket. So anything going over there. And throughout the year, there could be something going on where we need to add services. Like we might need to add another, we added the urgent care provider. There were more members like needing same-day care. We added another triage nurse recently. So there's the budget, and then there's also, as needs come up, things that we have to work with, so.
Every dollar that is spent in that health center would likely cost dramatically more if the services were delivered outside the health center. They run a pretty tight ship. Couple of other little interesting notes. We're cleaning up some things, and we're going to have a complete trend and analysis for you of the year. But a couple of interesting things. We had $4.2 million in claims from employees who are now terminated.
No longer on the plan.
Right. And new members into the plan last year represented 1.4 million. So if that can, if you can draw an inference, that's moving in the right direction. The top 10% of members in risk was about 873 people, and they represented 61% of their spend. And that's unfortunately what we see. That's the essence of insurance.
That's not any unique factor to the school district either. That's in
No.
most health plans. You'll have the people that have chronic conditions and definitely have illnesses going on will definitely draw the most money.
12% of all medical claims were funded by the employees, which means you're paying 88% of the cost, the plan is. And generally, that would be considered a pretty rich plan. Again, the top 10% of members represented 65% of the total spend.
Sorry, what page are you on?
I'm just
Okay.
riffing. Page 13 is really the same as page 12, just one time a year, because this represents, the rolling 12 is in fact the whole plan year. And again, as we mentioned before, we saw a rise in what are called the GLP-1, which is the non-diabetic use of the Ozempics and things like that. And so we took action on that. But actually, our overall RX spend is down from the previous year. And I think that reflects well on the controls that we're trying to continue to put in place. Page 14 is just a list of the employees that had more than $200,000 in claims for the year. That totaled $8 million, or 20% of the health spend. Not all of these people were in active case management, and we're looking into where that's appropriate and where it isn't. Someone with Crohn's disease can end up on this list, but that's not really something that lends itself to case management. Our kidney issue, our renal partner is doing an exceptional job, and we're reviewing some reports now. And moving forward, we're going to start, we're not going to share with you unless you want it. We would continue to share claims in excess of 200,000, but we're going to start monitoring claims above 75,000 to see if we can't keep some of these people from getting onto this list. Page 15, I'm going to turn it over to Mystery because she took the lead on this part of the project.
Yeah, so remember how Jay did that snapshot of the average high claimants? Well, like Barry said on the preceding page, we watch those high claimants because they do impact your stop-loss reimbursement. And we know that we had some questions during the stop-loss renewal. Well, what would happen if we had a lower stop-loss level? So we did kind of an illustrated example of what would have happened with those 20 high claimants if we'd had a lower stop-loss level.
So right now, our stop loss is at a 900,000, or
$1,000,000.
1.2. So, and then here in the gold, just see the alternatives there.
Correct. So right now, we have a specific deductible of 1.5 million with 135,000 aggregating deductible.
So we're assuming, on the first high claimant, we're assuming up to $1,600,000 in risk.
Right. So looking at the 4 columns, looking at Swiss Re, which is our current carrier, that's the one we renewed with. If you remember, Swiss Re offered us a renew as is rate pass. The annual premium difference with the current stop loss premium, if we had lowered our specific deductible to $750,000 instead of that 1.5 million, we would have paid 1.4 million more in premium. We had one claimant that reached 1.1 million. So that one claimant would have been eligible for stop loss reimbursement. So if we minus that 750,000 that we would have gotten back, plus the 135,000 or the $750,000 threshold, plus the 135 threshold, that would have given us a reimbursement of $269,035. So if we subtract that from the premium of 1.4 million that we would have paid extra, we still would have paid additional $1.2 million to have that 750,000. In the next illustrative option, if we had moved up to 900,000 reimbursement, or I'm sorry, stop loss level, that would have been an additional $616,000 in premium approximately. We would have gotten $119,000 back illustratively, but that still would have left us an additional $497 in premium differential.
I would want to point out, that means we would have paid $800,000 more for the lower stop loss so we're paying $800,000 for $250,000 for the coverage. But in fairness, at 900, you have the higher likelihood of more people piercing
Yeah.
the stop loss.
So, and just as, you know, I know it's been a few months, so I did include on the next page what you all approved.
And on page 14, just to show it, the highest we have right now is 623. So we're not looking at piercing that next year, correct?
The highest we have is $1,000,000.
$1,000,000.
Last year, yeah,
On
last
page
year.
Last year.
14.
No, but I don't want to say this, it sounds horrible. The employee deceased.
Oh,
Correct.
right,
You know what I'm saying? I'm talking about moving forward. I'm talking about
Correct.
moving forward.
okay.
You know what I'm saying?
Yes.
So the one that's still on the book, so to speak, is 620.
Well, now that you're a new plan year, none of these claims
Go back to
count.
zero.
They go back to zero.
But also.
The new plan
but-
year.
Oh, so this isn't an annual, this isn't
Yes.
rolling over?
No.
Wow, in 1 year?
Yeah.
Now, your point, though, is well taken. 42% of the people on this list were on the list last year, which means 58% of them are new to this list. So we're trying to track that and see.
But
where-
any that you see in green, those are either unfortunately no longer with us or they've left the plan. So any in green are no longer active
Right.
claims on the plan, but those that are in white, they're still active employees.
High claim.
We're
again next
members.
year.
They left the plan because
Various reasons.
Various reasons.
Changed employment.
Employee turned off the plan, spouse turned off the plan, and 2 passed away.
But we have a lot in active case management. So we're doing a lot to help people as well.
You know, our case management is focused on making sure that we're not spending the wrong money in care. But I've been particularly touched recently with the stories that we're hearing about these people that are in case management and how much they appreciate the guidance, sympathy that they're getting from the health plan. I think, you know, we get 2 stories a month about that.
Yeah.
When someone's going through a very large care plan, and to have someone who has become their advocate and their confidant, it's very important to them.
Well, and the case managers, they're like, so my friend was a navigator, a cancer navigator. So it's the same thing, right? They're the ones helping,
Similar.
scheduling things,
Similar.
making sure things are streamlined, all of that.
A navigator is going to help you find the right care. A case manager is going to handle all your care coordination and make sure that you're following up on your appointments and that the doctor is prescribing the right things and questioning different providers if if you're not getting the care that you need, and being the member's advocate, and then helping the member understand what's going on in their care. Sometimes,
Or family members.
yes. Yeah, we have some members that they have to have somebody else act on their behalf.
I didn't realize that was annual, I thought that was aggregate. I'm like, holy moly, that.
No, starts every year, yeah.
And so, man, I can only imagine that one patient over the life of them spent like $5 million possibly.
Maybe not their whole life, they could have, so if
Not
someone-
just recently, that most recent.
Ill, yeah.
the other one that was very ill. It had been multiplying over years, so getting sicker and sicker as time.
And if the reinsurer reviews the claims and they see this train coming at them, they're going to incorporate that into their offer. And they may say, yeah, it's $1.5 million for everyone, but for this person, it's $4 million.
Yeah.
So we keep a pretty close eye on this.
One thing we noticed, and we had a conversation with Lauren and her staff about, is for people to keep up with their personal legal documents with a will and
End of life.
end-of-life directives, because often your loved ones will.
No, I hate to say this, so that blew me away. I really thought it was cumulative. I'm sorry to kind of get over that. When something triggers that high an amount, do we have like some kind of audit to make sure there's no fraudulent charges in there? Because I can't think of $1 million. Did somebody excessively bill them on something? And I wouldn't say that on small little deals.
So it was.
No, I'm just talking
this
about, but still,
person
cancer
was
care or
very,
not. I
very-
mean, like, people
you're
can
talking
still
about in the hospital
overcharge
for
on
almost a
something.
year.
Because $1 million is significant, I'm not talking about doing that for like a $20,000 case, but $1 million case, at some point, it's like, somebody's, I don't know. I mean, I'm not suggesting that. That's the whole purpose of an audit, is to give us the surety that nobody's playing the game or playing the system. No providers, overcharging or something, because that is a lot.
So EDMS, our third-party administrator, has a threshold on when they ask for a detailed claim report. So if something comes in, then they start auditing with their audit team.
Itemized claims, as
Yeah.
opposed to bulk
Yeah.
claims.
This member here was in the hospital for essentially almost the whole year. But this member did not have advanced directives, and this member had vocalized what her intent was and how she was ready to pass on, but her spouse was not. And that was very painful.
I don't want to get into the specifics.
No, but-
I'm just talking about, and as a general
Yeah.
rule of thumb, as a
From an
school
audit
board policy,
standpoint, yeah.
when something exceeds 500,000 in a year, that we take like a more of a.
Oh, it's like
there are-
$50,000.
More of
Legislation,
a specific look than a claim of, say,
Yeah.
20,000 a
It's
year.
like at $50,000.
Yeah, no, with this one, we were almost daily.
Yeah.
Kenneth's not here. Do we want to go over his part for him? Okay. Carolyn, did you want to do it,
Sure.
or would you like
So,
me to?
no, I can take care of it. So on page 18, again, Kenneth was en route and he got a call for an emergency, so we were hoping he'd be here, but he's not. Over the quarters, the past couple quarters, you can see the commitment to recognizing that the care and the service level of the staff, doing a lot of training with them and getting them up to speed, and where they are as far as first quarter, second quarter, third quarter. You'll see a lot of, some of the reds gone to green in the good direction there.
So people, when implemented this survey, placed an operating talking with their partner on it to evaluate where they need to improve. And you can see most of the areas they've already improved on in the third quarter.
I like the detail, though. They're dicing it down to activities, specific activities.
And even things like, did the provider explain things well to you? Did you understand what the messaging was? How was the waiting area, the waiting time? All of that, was your privacy protected? And one of the area on page 19 that's highlighted is the easy appointments scheduling, and that is on everybody's radar, to get it where they can, for online scheduling, calling to schedule. And there have been certain people hired to answer the phones, because before the phones were being answered by the front desk people, so now there's PBX operators to assist with that. Oh, it's scheduled to happen?
But it's a response to this type of
Correct.
analysis.
So something like that is saying, if we can have somebody just answering phone calls, so the people, the front desk, can work on checking people in, and that whole process a lot easier.
And Carolyn spoke to earlier that we hired an RN. The RN specifically put into triage those calls like in the morning and say, I have to be seen today. They can talk to the patient, see whether or not it really needs to happen today, or if they can wait till the next day.
Or it's something that you could take care of on your own at home, or it's something that you need to come in later, or whatever the situation is. So that nurse, the triage nurse, is helping put out a lot of those little fires that people call first thing in the morning. The surveys, we always benchmarking ourselves. How are we doing? What is our perception with the members? And again, the numbers are, still very high, 4.89. That we're never still satisfied with that. We always aim on what can we do better on that. And the bottom still is a little tally showing how many people returned the survey. So what are we planning on doing this upcoming year? When we rolled out the new plan, what we were trying to figure out or trying to establish is, how are the people that were using the plan before, how are they engaged? Some members, we saw them for all of their care. They came to us as their primary care, they came to us for, physical therapy, they came to us for blood work, they came for x-rays, so they were all in. And then others just came in for a slice of what we did. So they came in just for physical therapy, but they still had their outside doctors. So when they elected the plan, we weren't sure, how did they engage with us before? So that's what we're discovering now. And as Barry had mentioned, what we're discovering is, as the data started to come in, is more and more people that selected the plan were already engaged somewhat, but they are the people that need more health care. So they're going to benefit from the plan more. And so we're really happy with that. Mystery did a really interesting analysis on, as the workforce here is very multi-generational, and how they interact with their care is very different. So
Yeah, so it's really interesting, because we talked a couple of times as we were introducing the health center only plan, is if we had a crystal ball to see what people would choose. And while, stereotypes are stereotypes, we do all have a tendency to lean certain ways on how we make our decisions, and with healthcare, that's no different. And for SDOC, you do have a younger population than some of the other school districts. And so we looked at some of the studies that they've done on the different generations. Believe it or not, you do have employees across all of these different generations. And so we pooled some reporting to see what your eligibility was for last year compared to this year, to see what that migration was. We knew we had 1,000 employees moving into the health center plan, but we wanted to see who were the employees that were choosing those plans, to see if we could identify how they were going to be utilizing the health center and how they were going to be making their choices. Just like Carolyn pointed out on the health center survey, ease of appointments was important. And if you're looking back on how people make their decision, a lot of what each generation wants is excellent service, comparison tools, digital options. Even Generation Z, they do digital offerings, Millennials, they're doing peer-driven rather than expert-driven digital options. Generation X is actively seeking and analyzing multiple sources. Baby boomers are online rating services, and silent generation is advice from professionals and quality service as well. So it's hitting across the board there. So when you're looking on page 24, I know it's a very full page, but we've got, in 2022, we had 6,386 roughly in October of 2022 enrolled. And then in October of 2023, we had 6,565 members enrolled. And employees. And so 78% of the SDOC population is age 26 to 58, just employees, not talking members, just employees. So that is a large population of Gen X and millennials. So as we're focusing on complaints and how we can improve and how we can add those services and making those ease of appointments easier, it's important to think of those things and how they approach healthcare as well. And then also, that helps us too to look at rising trends in what we might see for different things that might come up for services that we might want to include as far as for wellness and different concierge services for healthcare as well.
You know what would be a good enrollment metric to look at is how many employees are eligible versus how many are enrolled. So that way we can kind of look at it year by year and say, okay, are 80% of eligible employees in there? Are 50% of eligible employees? Like how many total employees do we have eligible?
We have about 1,000.
No, but if we included in the presentation though, like our regular updates, you know, like we always have goals, right? If the goal is to try to get as many people to use the health center as possible, it's nice to know what is the percentage of participation or enrollment, you know?
What was the number? You were about to say the answer.
It's about 1,000 to 1,200. I don't have it off the top of my head, but no more than 1,200 that opt out. And it's been consistent over the last few
They
years.
opt out because they're covered elsewhere. So
Right,
they're
opt
covered
out of
under
insurance in
retiree
general.
plan, they're covered under.
I think,
They
were
might have
you
a spouse
asking
or-
how many employees choose a healthcare plan? Is that what your question was, or was it just?
Or the percentage, and that's neat. That's neat to say, okay, out of that 1,200, they opted out
here we
because they
have-
have another one in there.
I mean, we
What's
have
the-
totals for that. If they opt out, though, it might not be.
No, not the
because-
total enrollment. No, I'm talking about like the total population of eligible employees. There's some employees that are part-time that
Oh.
aren't eligible for healthcare services, so they don't even have a choice. You know what I mean? But out of the full-time employees or 10-month employees, or whatever we categorize from an HR department, who's eligible to choose a plan, do they actually choose to use the health center? You know what I mean? Now, if there's not, then it's true. Then that just becomes a management note in that sheet of paper that says, okay, they chose not to because they have a spouse that has an equivalent plan and they chose to use theirs instead of ours.
So right now, we have a monthly report that we give to the benefit committee that has all that percentages of what plans are enrolled in, which ones that they've opted out. We have about 7,800 employees that are benefited. Like I said, 1,000 to 1,200 are the ones that are opted out. Everybody else is on the plan. It looks like 6,500 only because we have people that are, their spouse also works for the school district. So we moved them all into one family instead of having to pay the admin fee to EDMS. So that's why it goes down to 6,500 employees on it. But I'll be happy to bring that to the next workshop on it. To see how many use the health center, I'll work with the health center so that we can correlate that in that report.
And the reason for it is it just shows you how people like it. You know, I mean, if people are choosing it and there's a higher percentage of participation, then, you know.
And the great thing too, I'll just highlight here, is we did have great enrollment in the health center plan. We had great enrollment with Gen Z and Gen Y, the millennials too, and which is important because a lot of Gen Z, when they're coming off of their parents' plan, a lot of them don't have PCPs. So if we have them with the health center where they're used to that really really quality approach and that close relationship with their PCPs, then as we know from our other surveys and other studies, when you have a close relationship with your PCP, when you have that ease of relationship, the better care, the better relationship, the better health you have long term.
But you also tend to stay put. So
Yeah.
having them come into the health center plan at a younger age and they get used to it, and it's their view of how medicine is supposed to work, when they get into their 50s, they're likely to be in the same spot.
Did we have any kind of idea, goal, expectation for how many would enroll in that plan going into this year?
We came out
And it
right
came
on
out
like-
exactly what we thought.
Okay.
we had our gut feeling, and then we had Jay, our actuary, have his gut feeling, and we didn't really communicate what we thought, and it came out to be exactly what we
It
thought.
doesn't always work that way, but it was nice. Yeah.
Well, it's first year, you have so much, you know, what was different was the payroll deduction was such a difference for people. But it was the first year still. So they might say, well, let me watch it for 1 year. I can still use the health center, just not an all-in
Is there a
approach.
way to add to your survey an option for them to opt in to make their feedback, like be a testimonial for us moving forward and say, and they could be anonymous testimonial, but say how their perception of it or how their experience with it when we go into next year and trying to move
I
more.
like that.
That's a great
Almost like a
idea.
Google review almost, you know.
The most
Two-edged-
trustworthy
two-edged sword.
anonymous ones.
Well, them to opt in. We're not going to put their name out there if they don't want to put their name out there for it, but.
Dr. Shanoff already said,
Then we're gonna have Barry in there making testimonials
yeah.
all night long.
No, but if somebody had tremendous
Great
outcomes
experience.
and had a great experience, I mean, we've all done, I've done restaurants or whatever, had a pleasant experience.
Yeah,
I'll
I mean, and they
do it.
can share their
Yeah.
name if
You
they
have to
want
tell
to,
them.
but give them the,
So one thing that you guys,
Behind it.
not everybody on the board, but a couple boards ago that you guys allowed us to do was implement the benefit educator position in our department. So she just started this beginning of the school year, and she's been going out to all the schools. And one of the things that Dr. Shanoff has been very good at promoting is how better our benefits are than everybody else. Just because the premium might be a little bit higher here doesn't mean that you're getting the same coverage there that you are here. So she's going around to all the schools. She's a former teacher that's educating her employees on their benefits and letting them know if you go to the on-spot dermatology bus, things that would be not covered or you would have to pay a copay for are covered on the bus because our plan covers it that way.
she's one of our former teachers, or?
She's one of our teachers. She came from one of our schools, so we stole her from one of the schools.
It's just like quiz and stuff.
She just brings the
Pop
students
quiz.
quizzing them and
Replace her with someone else?
Is that what we're doing now?
Well, she wanted to
that's
have a
good, a
different career
peer-to-peer.
change,
Yeah,
so we kept her within
She's
the
not
school
with kids.
district.
All good.
here,
All good.
and they respect their peers.
Exactly.
They definitely do, and,
But she's giving out like little prizes and
They
contests
know the
for,
answer to the question that she's asking, and one of them, she asked, "What do you know what the disability company is?" Because it's important to people to have disability coverage. And only one teacher kind of went like this, and she's like, "Go ahead," and she had it right. So then the disability company gave her a really nice insulated bag that she can use for her lunch. She got that prize.
Dr. Shannon,
Yeah.
you were getting ready to say something.
no, I mean, I was gonna say that I've worked in 3 different districts, and the benefits, the health insurance in this district is significantly better than the experiences other places. And, you know, I actually, I'm super sensitive to the idea of, you know, if I make an appointment to go do something, I don't want anybody to know who I am. I would rather go in under an alias.
yeah.
But, you know, I did on spot very early on, before people knew who I was. And that experience was awesome. And I can't imagine what it would have taken to get into a dermatologist's office to get a spot looked at and then taken care of. But I was able to do it in 2 weeks. And then, yes, and then, you know, the follow-ups came with, you know, with the itemization of services and what was going to be charged, and then, of course, followed up with 0. You know, and as long as I can, I do intend to use the health center as my one-stop shop, because I do think that this is one of our better benefits that we offer
Wear a
our
fake
employees.
mustache when you go
I
there.
will definitely, like, wear the Groucho Marx. Yes, exactly. So, but when I make my appointment for my physical, I'm not asking to go in any earlier than the person who called in right before me. And wherever that places me in queue, that places me, but it'll certainly raise red flags if they say, well, you can come in whenever you want. And so that won't be something, that's when I pick up the phone and call Lauren and say, wait a second, this isn't right. So, I want our employees to be thinking about health center first. And I like the idea of trying to open up as many lanes as possible, so then people feel like this is the best option. Because I think it is the big differentiator between this district and other districts, so.
One thing with the health center plan, the immigration this year, there's a lot of employees that'll go right in, I already go into the health center, I'm gonna go to that plan. That was my fear. Those employees are the ones that love the health center already, they're gonna go to that plan because they're gonna save on their premiums. And they have their friend that goes to the health center, but doesn't wanna take that plunge at the first year, but they will next year. After those start spreading the word, the third year, you're gonna get even more population.
That's what we had to see and wait to see how it works out.
And as Mystery pointed out, as more Gen Zs come in the front door, they're more likely to gravitate to that solution.
And I'm Gen X, but I feel like Gen Z. And but I think you're right, and I think we need to be very cognizant of the changes in the number of employees that we're seeing in the health center. So then we can make that adaptation ahead of time, ahead of enrollment next year, when we do expect to onboard additional folks. So I think we just have to be positioned to accept all of those additional folks that may opt into that health center only plan. Because the worst thing that can happen is that all of a sudden we've opened up the floodgates and we can't handle the demand. And then all of a sudden they'll never come back. They'll leave, they'll never come back. So we have to be very protective over the responsiveness and the ability to get that appointment. I think is going to be huge.
And here's another thing too that kind of mentioned, because I was on the board back in the day when we were first thinking about creating this. One issue they had was.
That makes you Gen X, right?
Yes, I'm definitely Gen X. Or something.
Seriously.
Well, the reality is that there was a geographic decision-making issue. Like if you lived
Right.
out in St. Cloud, or if you lived in Celebration, were you willing to join the health center, even if it's the perfect plan for you? What are those dynamics? Are the number of people enrolled, are they all concentric, are they within 3 miles of the center itself? And what about the folks out there in Harmony, or even out there in
Why don't we do a
Poinciana?
heat map?
So we have done it already, yeah.
And it's really divided, it's basically equal throughout the whole county. We did also a survey earlier this year when LaToya started asking, what do you want to be educated on? A lot of the comments were, can we have more hours in Poinciana? We hear it from Westside a lot, we hear it from Harmony also a lot. So that's why I haven't talked to the boss yet. My next idea, if we can invest in the future, don't build an actual physical health center, but do a bus, like the OnSpot bus, that we can go out to those.
So just out of curiosity, maybe we could do like a little map to show like the dots, how many like per
We've
school.
already done it.
Yeah, so if you can show it to us, like per school, how many enrollees do we have per school?
I think that would be great, and I think that there's tremendous value with being able to move the center around to different locations. I think that that's one of the value drivers around OnSpot. So the idea that, it's going to be at Celebration for this week, and it's going to be, over in Poinciana this week, or whatever it happens to be. I think that that's awesome. I think people would really like it. I found OnSpot to be very much of a doctor's office when I went on the bus. It felt like a doctor's office, no doubt about it.
We did the heat map, not only where they live, but where they work. Because, we all, a lot of it is, well, I live over here, but I drive here every day, so would I want to go somewhere near where I work or live? In reality, unless you're somebody with a lot of stuff going on, how often do you go? And some of the follow-ups that we have, the providers do telephonic visits. So it's not like they're going every day. It's, if they go once a month or something like that, that's the whole, looking at that. But we did it both on work zip code and work and live zip codes.
Statistically, how has hiring been in, right now, post-COVID, I feel like a lot of companies and organizations struggle. Obviously, we do in certain areas. But if we are going to make that plan for ensuring that we are ready to go with more people next year, do we have a hardship when it comes to
So frankly, it's been hard.
Okay.
The healthcare industry itself is just hard to hire for. But People One has made a commitment. They've now created a recruitment tool for this area to bring in more providers for us.
It's getting easier as the word is getting out in the industry of that health center being so successful. It was a lot harder in the beginning, and I think it's catching on. And as we get more and more providers, the word is spreading amongst them
Do
too.
we have a survey for our staff there too, to see working environment, to be able to provide that for
I haven't seen one.
people? You know, as an option for people to see, especially when they're people that have worked in other medical environments, and do they favor being with us versus others?
One thing I did ask People One to do, Mindy and Dr. Shannon, so what are we doing well? What can we improve on? Questions that they were gonna bring to their staff. I'll see where they're at with that.
It doesn't seem articulated in some of these analyses, but I can guarantee you that if you look at the complaints that they're having or the lowest scores that the health center has, it's all about flexibility, which is what these three last generational things. They don't want to make an appointment. They want to be able to walk in and get it whenever, and that's totally a generational thing that 20 years ago I would have never expected in my life, and now today it's like, well, you can't walk in and see somebody, you know, like what is going on? So, I mean, wouldn't it, and I've had that experience, right, where you can't get an appointment or whatever, can't you, I mean, that, I think that if you want these people to come, just like they have to be invested in the outcome of the profit sharing process, then they also have to have the key thing to them, which is to be able to go in whenever they want, just have people there all the time, ready to serve them. And then you'll get the usage, which will reduce the negative, but it's an investment, right, at the beginning. But
So we did have walk-ins when we had Advent Health from the health center, and the complaint we heard was how long they had to wait because there were walk-ins. So you're gonna get a complaint no matter what.
because they are a walk-in,
Because they are a walk-in, they had to wait 3 hours, 4 hours that they didn't have because they're walk-in, they were trying to accommodate them. We've hired a couple of acute care providers, but we still want them to call in the morning so that we can make sure they're not waiting those 3 hours when they should be in the classroom if they're well enough to be
Or
in
if
the
they're
classroom.
sick, we don't want them in the lobby.
Yeah, we don't want them in the lobby, we want them to do it, and again, that RN also to triage it, so it's a little fine line on the walk-in piece. The Orlando Health Telemedicine is wonders, if you haven't tried it yet, they will prescribe almost anything that you need. If you get COVID, they'll do the antivirals. If you have the flu or whatnot, and you know that's what you have, they'll prescribe all of that for you, and it's free, there's no copay.
Yeah.
And the district is just paying $48 for that.
okay, well, that kind of would count, right? Like, okay, we can't provide you with that, but what we can do is this. And if they were waiting for several hours, then they didn't really have a walk-in model, right? They just had a policy that said, come in whenever you want.
Exactly, yeah.
Yeah, and as they engage and use it more, they learn, they have a relationship, and then they know, okay, so if I want to get this result, here's
gotta
the
play the game
process.
a little bit.
Yeah, well, just learn
Not
the
with this
system.
generation, I don't think that's the case. I think that,
But if they know I can call, or I can email, or whatever them, and then they can fit me in later, I think they'll do that.
But they like they have the virtual option.
Yeah.
They do, so the
I think
telehealth.
it takes a
they
one-time
are-
use, and then once they see the ease in it.
Yeah, I think
You
that this,
subscribe to it.
that the youngsters these days really do go with, they like telehealth.
Yeah.
They see it as a normal way of doing their visits, so, and I think that Lauren's team has done a very good job of really pushing the idea of utilizing telehealth. Certainly, I got myself registered to do telehealth should I need to use it. And I think a lot of people have found it to be very beneficial in a much easier way.
And I'm in favor of, I'm just one board member, I'm not really changing the model too much, because the more I think about it, urgent care doesn't take appointments at all. So they're designed 100% to take walk-ins.
Correct.
I can't just walk into my son's, pediatrician. Be like, no, you gotta have to take appointments, you know what I mean? So they're 100% appointments. So it's kind of hard to be a hybrid model to make everybody happy, because then it's just gonna make staffing levels and service times almost impossible.
Correct, but we do have those providers that are called the same-day acute care, meaning you just woke up this morning and not feeling well, so you didn't need an appointment for your physical, and so we have designated providers that are doing that.
Or I even like the idea, like you said, the RN that's doing triage,
Yes.
to a certain degree, they're doing that too. Somebody may call in and say, I want to walk in right now, because maybe they walk in by making a phone call saying, I want to come in today. Well, tell me what's wrong with you.
So it's
in
a
way, they're kinda
constant
getting a
tweak.
degree of care.
Correct.
Does that mean that you actually have the walk-in patients already kind of like in the formula for the staffing of the
Yes.
day? Okay.
The acute care.
Okay, so is there a way to visually communicate that to someone who might want to come in? So what I mean by that is, when you're driving around, there's these billboards for the ERs that say,
Wait
"Walk-
time,
wait
yes.
time, X, Y, or whatever." Is that, I mean, I think that's like, we're getting granular, that's not like any of our business technically, but just to kind of accommodate folks that are like, I really want to go in, I don't want to sit there for however long. Wait time for these specific appointments is X, Y, or Z.
Virtual care is 5 minutes. so-
Oh, they should do virtual
They should
care,
be-
but, you know.
Yeah. But
I might-
if
I
someone
might
wants
wanna walk-
something like
yeah.
for the acute care, they
Yeah.
call every day, and those appointments fill up fast.
Yeah.
So I don't know if
We're
there's any like.
online. I haven't booked an appointment online, but online, that would be like something also to, because I feel like if we do, like if I've done advent care, like
Yeah.
for my kid who broke a leg or something, I could see like what appointments are available
Correct.
that day. I don't know, that's probably too granular for
Certainly
y'all,
would be
but,
friendly though, no doubt about it.
yeah.
I'll ask them.
But we should take care to not hold the health center to a higher
No,
level
absolutely not,
than the
of
general
course.
population. You know, like you said, trying to get into and see a dermatologist.
Oh, 6
Good
months
luck,
at least.
you know?
I mean, I think that we should. That would be the differential between some place. I mean, here's the thing. Healthcare is not a popular industry,
Right.
right? And it doesn't have high credibility when people are polled. So why is that? It's because of the difficulty of it. It's because it's such a complicated process. No, people don't walk in with a medical degree, right? And so to provide them the service would make it better to come work here and receive your health care better, right? So I mean, I think that we should look exactly what the standard is and then make it better. I mean, that would be the goal, right, for anybody who's profiting on.
Yeah, and especially if it already exists. I was under the impression that we weren't. But if you're gonna have it, to Terry's point, at least have some kind of tracker, either physical building that says outside the wait time or online. You know, if somebody's gonna make an appointment or they wanna look at it, they can look at it online, say, okay, the wait time is 50 minutes, whatever. I may just go ahead and just drive in, or go to an urgent center.
When your ticket says 58 and it says now serving 4,
But if I see
Yes.
that at home,
That's the point.
and I can make a decision at that point whether to go to the clinic and sit there for 2.5 hours or to do telehealth.
Right.
You know what I mean? It's just,
Yeah, it helps you to make that decision.
On the back of that ticket, it
Yeah,
should have a
at least
QR
it
code that tells you do
clarifies,
telehealth instead.
There's no walk.
Now, that's a good point.
No,
On
about
all
your
of our,
acute care.
on all of our
I get it.
communications, it should prompt
Yes.
virtual.
Yeah. And we do with the front desk now, when they know that there's nothing available, that's the first thing they do, is they have you try the virtual, and then they'll go down the line of the urgent cares that are in our area. One other avenue they have is prescriptions unlimited. Pharmacists now can test for flu, COVID, and strep.
Right.
And they can prescribe based on those. Even if you go in, you get tested negative for all of them, and it's a sinus infection, they can still give you it.
The pharmacy can
The
prescribe.
pharmacies. Prescriptions Unlimited has that drive-through, like they did for the COVID booster shots and the testing. They use that as well for it. It's
So you have to go to the
$15.
St. Cloud one,
You have to
though?
go to the St.
Okay.
Cloud, and it's a $15 copay for employees that want to do that.
And keep in mind though too, I mean, on the opposite side of that is you don't want members to feel like they have to rush through their appointment with their provider. So they want to feel like they have their provider's attention and it's not just a 5-minute appointment or a 15-minute appointment. And they have to be rushed out of the door because there's that clock ticking.
yeah.
When you were asking about what's the benchmark it compares to, on the surveys, like on page 18, the first column here is the national average. So that's where they are saying, are we better or lower than the national average?
Yeah, so I think it's 70% down. We're to the bottom right, last column. So we're like floating at about 70% in one of those where it's really low.
On the
Well,
scheduling?
Appointments.
No, right there, yeah, exactly.
Yes.
So, on that one, that's purely generational flexibility requests that are being denied because there's a cultural difference in, generationally.
And doctors'
right? And their
offices-
demands are completely different.
Doctors' offices aren't known as being, as far as schedules and things like that, but
Yeah.
high-tech.
Yeah, that's true.
So
Yeah.
they're high hands-on, they're high-tech with technology to, diagnose you, but as far as
They're
front
still
office
using
staff.
faxes.
Yeah,
Yeah.
well, fax is because it's HIPAA compliant.
Yeah.
they don't email, so it's
Yeah.
things that are maybe not as efficient as what we think.
Did you want to go over the advisor initiatives? Sorry, next slide.
As we always are going over and thinking about what is the next thing for us, you know, for the past 3 years, a lot of it has been making the plan more stable. You know, when we started, you know, we were in the middle of a pandemic, so, but making the plan more predictable. How can we massage it and educate the members more and more? And then we want to say, okay, what's next? How can we make it even better? Not only with bringing in more providers like the on-spots and things like that, but also for member care, and how do we address things that we're seeing so much? And one thing that we see so much is cancer. There's so much cancer. So there's two sides of cancer. There's helping diagnose or early detect cancer, so a lot of screenings. And then there's also when somebody has cancer, the special attention that they need, because it's a scary thing. So we're looking at both sides of those, from the whole as far as preventive screenings, but also there's a lot of stuff with genetics going out there, and with all of that stuff with cancer predictors. So we're looking at all of those. We're looking at more claim trends, and we're looking at all of our vendor partners. Are they the right partner as far as being integrated in our system, price points, service-wise? So we're doing an evaluation of all of those. So that's what we have going on this year.
Cancer is down 4%, but it moved from our number 2 diagnosis to our number 1 diagnosis
It's down 4% in our population or in general?
in our population. But I think our team, once we get past the interesting period of transition and putting a new plan in, cancer is going to take up a lot of our focus on what can we do to lower costs, but provide better care and earlier detection.
And better outcomes.
Right.
So we have a new mammogram bus vendor that we're in the middle of contracting to start hopefully in the spring. It'll be at the 5K so employees can get on the bus and check it out. Learn from some Polk County schools. They have several school districts in the state of Florida already.
It's 3D.
It's 3D.
That's good.
So that'll help us. Again, as the current mammogram vendor, we've had some issues with our employees and maintenance.
Have we freed up time in people's schedules? You wanna-
No, because we have a 4 o'clock.
Oh, you did?
I thought it was, I didn't know you had a 4.
Oh, no, we're 5. We don't care. Don't we have a 4?
We do not have a
Facilities?
We only have this.
Wait, facilities isn't today?
We just
No.
gave
No,
you 45
merciless
minutes of your
when
life back.
Never
You're not
mind,
today, are
then
you?
you
Come on,
can
Dave,
keep
you're-
going.
4 o'clock is a nice little break.
No, you can keep going. I love this stuff. I mean, there's like,
Carolyn, you want to?
No.
Just high level, the sky sail?
Or your phone.
Sky sale report is to remind you guys, Sky sale, they monitor our pharmacy plan for us. So we have our PBMs and Integra. Sky sale is the advisor on the pharmacy side, so we rely on them on looking at everything for us. So this is the last year in review of their report. Going through it, spend overall has been pretty consistent with everything. Sorry.
Do I just add that this report is from Milliman Sky Sale, when it's only your Ventegra, your pharmacy vendor. Anything in green, we thought was important to add about, that's the international pharmacy. So we just added that info for you, so you had a total picture. Back to you, Lauren.
Sorry. So slide 29 has the, how many claims,
And
the total
apologies
cost.
for that PowerPoint presentation, the numbers might be off slightly, but the numbers in front of you are correct.
Okay, this is the correct one.
Yeah.
Sorry. So our total cost per RX, $116. Average cost per specialty RX, if you see that's always the highest one. That's like the Humaras that we talked about, the Ozempics of the world. The next page is per member per month on how much we're spending, how much goes to pharmacy and how much is our specialty and how much is non-specialty. generic dispensing rate is pretty high. It's a little bit lower because we do a lot of the vaccinations in there, so it drives down the generic dispensing rate for us. Again, prescriptions unlimited goes out to the schools. There's all the flu shots this year. The flu shot campaign included shingles for that population that needed a shingles shot. Last year we did pneumonia and COVID last year.
So all those are brands.
Yeah,
That's why
I
that's
think people need
variation.
to know that, because it's kind of small, it's 601, right, is the, like, the drug type, you have like the brand versus the generic 21. I thought it would have been like 50% of the cost, man, it's not even
Oh, it's
20%.
Oh, it's pennies.
So that's a
Specialty
huge
is
difference.
driving your cost.
That's why you should always try the generic first. So next is by drug type, and they call it channel drug type again, specialty drugs versus standard retail. The international program, ministry added those numbers here so you can see those, how much the specialty are costing us for the international in the last year with that total. Specialty claims are 0.7% of the scripts and 40% of the overall drug cost.
Right there.
So that's a very small percentage, but a very percentage in the cost as well.
1%, but it's, no. Correct.
So the next one, next slide, it tells you where our employees are going. Publix has the market for us. The Health Smart there is actually Prescriptions Unlimited and a couple little other independents. But most of our employees are going to Publix.
And we want that,
We do.
because, I mean, we want them to go to Prescriptions Unlimited, Publix, or Walmart.
And
We
you'll
don't
see-
want them going to
You'll see
CVS.
why on the next page.
Yeah.
Now, one thing though is, I think this year we wanted to stand up our own pharmacy or something.
Yeah, that's
But
Prescriptions
is that-
Unlimited.
Oh, that's a prescription
That's the
limited.
Health Mart. Those,
Oh,
those
Health Mart, okay,
independent
I'm
pharmacies.
sorry, I didn't know the health.
There's a couple of slides for just the health center pharmacy coming up as well. But the next slide will show you what our average wholesale price acquisition discount is. You see Publix discount is the top, followed by that independent one. Walmart is in there as well, but that gives the actual percentage of what we're paying, what we're saving, that discount.
The interesting thing is when we get reports, is not only are we getting it less expensive, but the dispensing fees that those places are charging compared to those other two name brand pharmacies are outrageous. So I mean, we're significantly lower. So this is the ingredient cost, but also the total cost with the dispensing fees. When you see them, it's crazy.
And our members are paying. Our
No, the plan is paying for that.
Yeah,
The member just pays their copay.
It doesn't matter to them out of pocket.
Correct.
And of course, then they can have the coupon on top of it if they're not spending anything, so. The next page gives the top name brands and the cost for all of them. Again, the Humira pen is the one that went biosimilar, that we're trying to move people over to the biosimilar. And the 14.2% of the overall spend are for Humira, Ofev, and Stelara on the specialty.
Look at those average costs on the right. It's frightening. That's per month.
Yeah, that's a monthly cost.
How many of those are cancer prescriptions?
None of those are cancer.
Oh, really? I thought that would be the highest driver.
Nope, most of them
No,
are
cancer-
anti-inflammatory.
Cancer is usually included in injectables.
They're usually in
As opposed,
infusions.
it's called a J code. It's covered under the medical plan, not under the pharmacy.
Well, there is one oncology thing here. It's, what is that?
Sprycel is a leukemia drug.
Leukemia, okay.
Because anti-inflammatories, isn't there like this, isn't there like Flexerol, isn't there like so many alternatives? Why such an increase in specialty drugs? I thought, just assuming the specialty drug would have been cancer or maybe diabetes, but anti-inflammatory, there's ibuprofen.
Like rheumatoid arthritis.
Rheumatoid arthritis, things like that. So it's
Skyrizi is for psoriasis.
Yeah, so it's,
Psoriasis is expensive.
yeah.
My kid had it. Not psoriasis. She was on some kind of topical that was like outrageous, and I was like,
Probably for psoriasis.
yeah.
It's what you see on TV if you watch the news.
The
And
VA gives you ibuprofen for cancer too. It's, so one prescribed, one magic pill, that's it.
Stelara is 20,000
If you get
a month.
decapitated, they might give you that.
What's important to point out none of these pharmaceuticals cure anything.
Correct.
Just
They're meant to
maintenance.
maintain, which means forever.
So then the next one is just SkySo's evaluation of the biosimilars and what's available and what's not. The following one is non-specialty brand name rate performance. So you see that Ozempic diabetes is highlighted with how much our cost has increased. Same with the Rybelsus, it's also highlighted. They're more prevalent on the plan, and that's why we implemented the need to be actual diabetic instead of using it for weight loss. We had a lot of employees using it for weight loss just because they might be pre-diabetic or insulin resistant. That's still not the diagnosis yet. They could try other medications first, and that's what we pushed them back on to do that.
So those other medications are a lot more appropriate and also a lot more cost-effective for the plan.
And we did that not just with Integra, we did it also through ElectRx. They contacted all the physicians to make sure that we had the actual diagnosis. So these are just trend lines on the injections, orals, and insulins, for the growth cost by quarter. Again, the international diabetes RX cost is highlighted in the upper right-hand corner. And again, that GLP-1 product, those are the Ozempics of the world, the Trulicities, and how that did each month and each quarter for the last 2 years.
Is everybody familiar with what a GLP-1 is?
It's that class of drugs that we're talking
So the
about.
Ozempic, Trulicity,
Rybelsus.
So they mimic the GLP-1 hormone. So that, it basically inhibits the insulin absorption. Am I saying that correctly? So it basically makes it so that, the side effect of it is that your stomach doesn't feel as hungry. It's like that appetite.
There's one also that you take and it pushes out the sugar as well, so your body's not taking in those calories, it filters your kidneys out.
And that's why it's being used as a weight loss drug.
Correct, but I'm sure that you've seen that when anything gets really popular, there are also the other side of the coin, that we're seeing a lot of different side effects for these patients now. And you're seeing the commercials on TV for the class action lawsuits are coming up now. So it's scary, and people need to be aware of what they're taking.
We'll skip to your slide 41. This is just how the plan has done. SkySo analyzes and says overall we're overperforming what we have contracted with Integra. So
This is what you asked earlier.
and the statement 30 and 90 day generics and specialty channels are driving most of the overperformance. So if you're getting the retail generics and specialty, that's driving it. Again, the specialty is fulfilled by prescriptions unlimited, so that's helped us without the dispensing fee, there's a slight difference there in actual performance on it, but it's just minor when it compares to the performance of the plan.
What page is that?
42. Then the net plan utilization details, this report is very detailed, so I'm not gonna go through all of it for you, but it gives you the categories of it, how much the per member per month spend are each one of the different categories. And by plan, the health center utilization represents $22.27 per member per month amount, not included in the figures above. You just add that to the figures above, and then Mystery again added the number of international prescriptions here for you.
Doorbell every time somebody opens the door.
So then if you go over to slide 45, this is specifically on the health center pharmacy and how those claims are coming through. They had 21,448 claims since inception in January. The total cost per the member is $7.81, and the plan is $100.31. If you want to go back to the member, based on SkySo reports, doesn't count any coupons. Eric might be able to find. So if they're getting their Freestyle Libre for their insulin, or not theirs, the average glucose on, it's a wearable, there's a coupon for that they can get 3 months supply for $45, so it lowers our copay for them, so that's not as part of this measurement. Average cost per brand for the plan, and then per generic with the total with specialty as well, with the cost is out of the health sector plan. And since the members pay zero for generics, it's a huge advantage to them, which again, that's what we're educating employees on. Even if you don't go to the health center, you can go to the health center pharmacy, he delivers for you. You get that savings. They have an estimated percent of utilizers on the next plan, which is 33.5% of the population. And then the pay per member per month and plan spend, which is $22.27, which is a great deal for everybody.
Now, I know it's not good from a cost perspective, but from a humanitarian perspective, I do appreciate the fact that we're looking at it as far as giving them an incentive to use a generic and not cutting them off and saying, you know what, you're not gonna, because some people, you never really know, I mean, they might be attached to it for whatever reason. Sometimes I always hear with some employees tell me that they might be allergic to the generic or something like that, or they might have some kind of reaction. So, or sometimes there's just some psychological attachment to that drug. So, I do appreciate the fact that you guys are approaching it from, let's try to convince them voluntarily, rather than saying, you know what, we're cutting costs, we're gonna be like the cutoff point.
Well, it's the
That's
price
it.
point. So if there is a generic available for a drug, we make it much more affordable on the generic side. There's two different types of requests for a brand name. There's one from the doctor who says they need to take the brand name drug. And then there's the employee that just feels that they want to have the brand name drug. So depending on how that's written, there are different protocols with that. So there are certain drugs that the brand name is allowed at no differential to the employee. There's for Synthroid and certain people that have seizure medications. But on that, if the employee wants the brand or the doctor wants the brand, that there's a higher cost for that because it costs the plan more.
And we learned from Bentegra when they were in town a couple of weeks ago that the physician, when they're talking to the patient and the patient insisting you have to need the prescription for X drug, I don't care what it is, they just write it hoping the plan denies it. So they can just blame it on the plan instead of themselves.
Or how about, here's another way, and I'm just throwing, I didn't really think it through, so if it's a bad idea, I agree. But you remember you just talked about earlier, that if a specific drug wasn't good, it'd be from tier 1 to tier 2, same thing with providers. Well, what if we hold a doctor accountable like that too? Like if we look at it and say, okay, that script wasn't really needed, and we found out that 50% of the scripts they're writing are generics, are not generics, and make them a tier 2 doctor. 'cause
So
even
when the
though-
doctor writes a prescription for a name brand drug, the plan default is if there's a generic available, the generic will be filled. So that's the way the plan is defaulted to.
That's
And
been
that's,
my
that,
experience with my-
that's the
my
automatic.
medication.
And so, usually they don't get written for the generic name, they'll get written for the brand name, and then it gets filled with the generic name.
It's
Also,
also-
the employee doesn't even know.
Right.
Well, they know because they
No, I
know a
know,
copay.
Know when they get it.
But listen, I mean, mine's written as the brand name, Radvair, which is an asthma maintenance medication. And I always end up getting the generic. I'm happy that, I'm not necessarily sending that money on to, big pharma. I'm good.
In the past, the doctor could write DAW, dispense as written. But even that is becoming rare.
And also there's the steps as well. So say they
You get generic
tried
drugs.
generic and it failed, then we have the next most favorable brands for them to try. Those, again, the physician's gonna have to submit documentation that those failed. Then they would go up to the next
Correct.
one. It's a step therapy to gradually move them to the higher cost. So if you're newly diagnosed diabetic, you're not allowed to start on Ozempic right away. There's the common
That's to
industry ones.
stabilize.
It's the metformin is the first one they'd always put you on, and that's a generic medication for glucophage. It's been around for I don't know how many years, but a lot of years. And that's what we have them try first before they move up to the more.
Your point is we're not in the business of saying no. You can't
Or
do
not
it.
telling doctors what they can and can't do. I mean, that's their relationship.
So again, the Humiras are the top spend for the specialty out of the health center pharmacies, because they're overall the same ones for everything. That's it on that report.
Um, I just wanted to say that Lauren and Lauren's team are amazing. They're super responsive. Anytime I get emails from employees and they have specific concerns, I send them over to Lauren, and Lauren spends the time And it's sorry, yes.
Lauren
yes,
spends the time to
Tasha's
tell
on, yes.
Latasha.
So, but I think that the level of customer service that our employees are getting from the Risk and Benefits Department is outstanding. And so I think, obviously when we have these updates, it's very clear that you're on top of everything. And we appreciate the partnership. There's no doubt about it. And I'm not taking anything away from anybody who partners and has a business relationship with us. But I think that you guys would concur that Lauren is, and Tasha, sorry, are amazing professionals. And I think at least for our 8,000 employees, I can't think of a better, more responsive department than Risk and Benefits. So appreciate everything that you guys do.
We would concur.
And not only a fiscal concern, but I mean, just the heart is
Yeah.
is there. We've got Lauren on video a few times, and you can tell the heart is
Well,
there.
we all
So-
know that that's why we joined forces and why we joined a partnership was the heart. And we care about all of our members, whatever they're planning on, but by all means, the school district is a strong partnership, and we always say it's people helping people. You can put in technology, you can put in all these different things, but it's people helping people, and that are in time of need for care, they need it. And so we guide and partner, and just have Lauren and her team embrace such a unique style and such a unique plan as we rolled out, and now she's the face of it. So,
Thank you.
Appreciate it. We love what
No,
we do. Latasha will be
The only thing is, on a side note, thinking strategically, thinking long-term, because we're kind of redoing our strategic plan and stuff like that. Because I was a medical professional back in the day. And a lot of times, before you get any certification, you have to have a certain degree of internships and apprenticeships. I know Valencia College and UCF, they have their own medical programs and things like that to become an RN, LPN, CNA, whatever the case may be. Have we thought about maybe one day, we talk about increasing bandwidth, and not increasing costs, have we thought about, or marginally increasing costs, because they cost something, to have interns in there and kind of.
I think we have, but
Prescriptions Unlimited already has the pharmacy techs that work outside of our pharmacy, and People One recently signed with CTE to get MAs, phlebotomists, and one other one into the health.
We have an intern.
Sarah's, but I think the issue was if there was a teacher who came in and saw her student, or his or her student at the medical center.
I
there
think
was
we
that.
originally talked about that with the school districts and
Yeah.
scholarships. Like if somebody, because we have our own medical, I'm talking about like now differently.
Oh, yeah,
Like
high level.
Valencia
Yeah, gotcha.
or UCF. So
Yeah.
I understand like internal and students
Yeah.
within the school district. I'm talking about outside.
We haven't approached that yet. We started with the school district, and we're doing the interns that are 18 and older, so the adult population,
Right.
the students that are in high school. But yes, that's something that we'd like to pursue.
Dr. Shanoff, we will need your testimony, and we'll.
And your colonoscopy when
Yeah,
my
I was gonna
phone-
call you.
That's gonna be anonymous.
So,
That's gonna be
no.
anonymous. We're not gonna say it's the
Here's the
superintendent.
thing. So yes, no,
Can we stream that on YouTube?
It's being streamed at the moment, right now. We are
absolutely
on
will do
air.
that. So I actually would like to, so I need to get my referral from the health center to get my colonoscopy. So when that
text right
happens,
now.
though,
That's
TMI. When that
Wait to
happens,
tip
I would
will be
like,
in the room with
I
you.
would like community relations to document the entire experience. And actually, maybe they could deputize Frank to be a member of the community relations staff just for that day.
Sure, the doctor's got a lot of hose.
Okay.
And on that note,
Let's go.
Frank.
I'm done with this. Happy holidays.
Happy holidays.
He might.